Hi, I'm Helen.
And I'm Kirsten.
Welcome to Hello Down There by Pelvic Health, where we encourage you to feel comfortable about talking about uncomfortable health issues related to pelvic health and wellness.
Today, we're excited to introduce Lauryn Beecher, who is a doctor of physical therapy, a pelvic rehabilitation practitioner, and founder of Pelvic Health and Wellness, Milwaukee's premier pelvic floor physical therapy center. Hi, Lauryn.
Hello. Thanks for having me on today.
I'm excited to have you here. And I have to tell you, part of the reason I'm excited is a pelvic floor physical therapist here in Miami changed my life. And I can't wait to introduce people to you and your world so their lives might be changed too. So let's start with kind of setting the stage, Lauryn, for our listeners. A number of people may not be familiar with the role of a pelvic floor physical therapist. Could you describe a little bit about what a pelvic PT is and what you specialize in, and perhaps share a little bit about your journey and how you came to be a pelvic floor physical therapist?
Absolutely. So when I went to PT school, I admittedly had no idea that pelvic floor physical therapy was even a thing. I figured I would do pediatrics or outpatient ortho, kind of what you think of when you think about physical therapy. And I was fortunate enough that the university that I went to had a women's health course, and that completely changed my entire career trajectory. So I was learning about all of these things that so many of the moms that I knew and the moms that I'd nannied for and babysat for, that they were dealing with. And they were told, what did you expect? You had kids, wait till you're older, we'll do surgery. The things that so many of my clients are sadly told. And when I learned, you mean physical therapy can help with that? And you don't have to have surgery. You don't have to have, medication side effects. And it works really well. That was what I decided I wanted to do.
Incredible. Well, thank goodness you did, because there is a everlasting need for you and your practice. So talk to us a little bit about what does that mean to be a pelvic floor PT? And I know that seems like a very basic question, but believe it or not, on my own journey, I didn't even know what pelvic floor physical therapy was until I got up and close and personal. I didn't even know it existed from a consumer perspective.
Yeah, so from the consumer's perspective, I think it's really important to ask questions of your provider, whether they are a pelvic floor PT or OT. The biggest thing to ask is, how much of this do you do? Because there's so many people that are out there just dabbling. They're like, oh, that sounds interesting. I want to help moms. And there's so much more to it than helping moms that pee their pants. So asking them, how many pelvic clients do you work with each week? Is that a big part of your practice? I think is really important. The other big thing can be asking, do they do internal work? So there's no other muscle group. I wouldn't say I'm a shoulder specialist if I couldn't fully assess all of the muscles of your shoulder, your neck, the middle of your back. So really being able to evaluate and assess everything at the pelvic floor.
It's really important.
So let's take it. Our podcast, as you know, is all about generating awareness about pelvic health in everyday terms for women, so non-medical jargon. Could you briefly explain what pelvic floor dysfunction is and how that might manifest in different types of pain?
So pelvic floor dysfunction is a really broad term. When I hear the word dysfunction, I think about basically anything that can go wrong or isn't working quite right in the pelvic region. So when we talk about pain specifically, it's pain anywhere in the pelvis itself. So anywhere in the hip region, anywhere down below, as you'd mentioned. And that could be pain with sitting, could be pain with sex, pain with bowel movements, pain with urinating. So any type of pain that's kind of below your belly button and above your thighs, I would consider that, pain related to pelvic floor dysfunction.
And we have heard quite a bit from others that we've spoken to about the sort of mind-body connection. is there a role between sort of the mind and your pelvic health? I mean, other than the obvious that most people would think about, that the brain sending signals that you're in pain, but other than that, is there a mindfulness or a health related to pelvic health?
Oh, absolutely. So the pelvic region is one of the only areas in our body that gets input from the two major parts of our nervous system. So a lot of the people that I work with, we're working on, mindfulness around how do you feel in your body? Because this is a really emotionally charged area. If I can't sit or I can't wear underwear without extreme pain, and I can't necessarily talk about it openly either. So I think that's a really big part of it. It's different than if my knee hurts or my ankle hurts.
Mm-hmm.
So these two parts of your nervous system that are coming together that are both really upregulated and really upcharged. And we're working to help calm that down, find some center and find some balance again.
So staying in the realm of pain, as you mentioned, pelvic floor dysfunction is a very broad term, and there's a number of different conditions that fall under that. We wanted to talk a little bit about vulvodynia. Can you talk a little bit about what that is? I know people might hear that word and be like, vulva, what? And not like, what are these? Some of these terms,
or even be able to say
complicated on the surface. Or not be able to say it. Yeah. So let's talk a little bit about what it is, and then also what psychological factors might play a role in conditions like chronic pelvic pain or vulvodynia.
So I think it can be helpful to break the word down a little bit.
Let's
so
do
we
it.
talk about vulvodynia. If you know the word vulva, think about, the mons pubis, so that area below the belly button, before any openings, and then the labia, so the labia majora, the labia minora, basically the lips area, all the way down to just above the perineum, or that tissue that connects the vulva, the vaginal opening, and the anus. So vulvodynia is really any pain within the region of the vulva. So it's a pretty large area.
Yeah. Yeah. And, I think the way you just broke that down is very helpful, because I'm not sure we all know where all those parts are, or where that all extends to. So I think that in itself is very helpful. Can you talk about some of the psychological factors that go into pain you might be experiencing in that region specifically?
So I think a really big part about the psychological factors in pain with vulvodynia is that it can be really isolating, and it's an emotionally charged area. When we think about our society as a whole, a lot of people don't even feel comfortable saying the word vulva.
Yeah.
Not unusual that when someone comes to me with vulvar pain, that, they're like, oh, it's down there. I'm like, well, down where? There are lots of things going on.
Yeah.
So being able to, get my model or pull up a picture to be able to just give someone an image so that they can really see a reflection of their own body for the first time. So when we talk about the brain, if I don't have a really good image of what my body looks like, that image, it's all smudged in the brain. Yeah. It's really hard to figure out what exactly is going on. Where is that pain coming from? And then if I've been shamed or someone's brushed me aside when I said I have pain down there, I have vulvar pain, it hurts to put a tampon in, it hurts to sit, I can't wear underwear or jeans anymore, and they give me a funny look, it's really isolating, and I might not ever bring it up ever again.
Yeah. In talking about vulvodynia, what from your where you sit as a pelvic PT, can you talk about different approaches or therapies that are effective in addressing vulvodynia?
Yeah, so I'd say one of the biggest things can be figuring out, is there a specific area of the body that's contributing to the pain? So sometimes it is the pelvic floor. Quite often it is. Where there are issues with how those muscles and soft tissues are moving. But sometimes it's also the middle of the back. So that's an area that can get ignored quite often. So seeing someone who really looks at your entire body, looks at you as a whole person, and can say, oh, those joints in the middle of your back, those muscles in the middle of your back, they aren't moving really well. That could be a part of treating your vulvar pain.
Yeah, I don't think you'd make that, like, as a general consumer, you'd make that connection at all.
I think we dismiss lower back pain a lot as well, or different variants of pain. We dismiss it as something else because, we're not medically trained. We wouldn't think to put those two things together. So that's interesting.
Yeah. And then, of course, looking at the vulva, at the pelvic floor muscles on the outside and the inside as well. It's this whole sling of muscles that provides a lot of support to our body. So anytime there's pain, we tend to tighten and clench our muscles. So for a lot of people, just connecting with the pelvic floor, feeling the pelvic floor move as they breathe or stretch, starting to feel comfortable with some gentle movement, some gentle stretch, can be a really big part of that initial recovery process.
So staying in the realm of pain, there's another big word that we want to talk about, which is dyspareunia or painful sex, which is another one that women often suffer silently from. So can you talk a little bit about dyspareunia and also maybe some of the nuanced differences between vulvodynia and dyspareunia? And yes, that's another word that if you look at it, people are like, what is that?
What is that? Yeah.
Oh yeah, I hear all kinds of interesting pronunciations, and we figure out what people are trying.
Did we mess it up?
We did. You
Can we just call it painful sex? It's easier.
So dyspareunia, you can think of as another subset. So with vulvodynia, there are two main types. There's provoked, which means if I touch it and it hurts, that's provoked vulvodynia. Unprovoked is when it just hurts even without something touching it. So vulvodynia is more describing the area where you're feeling pain, whereas dyspareunia is specifically pain with intercourse. I'd also extend that to pain with any type of insertion or penetration. So that pain could be at the opening or around the vulva. It could also be deeper within the vaginal canal. So there's some overlap there.
There's some overlap between the two. And are there, just like with vulvodynia, are there specific treatments for treating dyspareunia that you would take as a pelvic PT to kind of help reduce that pain upon insertion?
So again, there can be a lot of overlap. We see quite often when we're talking about pelvic pain that just mapping out the body and figuring out, okay, where exactly does this hurt? Can I move my hips? Can I move my low back? Can I allow my body to move? Because I've probably been pulling in my abs and my pelvic floor and everything's really tight around my glutes. So finding some movement to start off with, and then seeing, are there any specific tissues or nerves that are stuck and aren't moving well? And from there, we figure out, do we need to get the nerves moving first? Do we need to do soft tissue work, mindfulness exercises? What works for the person that's sitting right in front of you?
And is that where some of the more, I guess in both cases, is that where some of the more internal work? And I want to go back to that because I think our listeners may not fully grasp what internal work means, but it's absolutely critical in this type of work. So in the case of dyspareunia, can you talk a little bit more about when you're saying soft tissues, are you talking about some of that internal work that occurs? And can you describe that a little bit?
Yeah, so that's exactly what I'm talking about.
Yeah.
So one thing I do like to clarify, and I go over this with any of my clients before they ever take their pants off, the assessment that we're doing, it's very different than the assessment that your OB-GYN or your midwife would be doing.
Yeah.
Looking specifically at how do your muscles coordinate? How do your muscles move? Not necessarily looking just at the cervix or anything like that. There's no speculums involved. And I know in my practice, at least, you're laying down on an actual, massage table. There's a heated warmer on the bed. You aren't scooting all the way down to the edge of the table, with your knees wide open, feeling like you're going to fall off the plinth. So it's very different. There are no speculums involved. And you're also sitting in a way that I can see you. So the entire time we are communicating, I'm talking through, here's what I'd like to do next. You're telling me, okay, I'm ready for that.
Okay.
So when I assess the pelvic floor muscles, first thing we're doing is just taking a look at the outside. So at the vulva, seeing what happens when you breathe. If you try to contract your pelvic floor, you try to relax or bulge or bear down, what happens? So that initial connection.
Yeah.
And then from there, just a gentle touch on the outside, seeing how are these muscles moving? Are there areas that are tight or sore? And then we do a little bit of lubricant and do the same thing on the inside of the vaginal canal. Also assess the muscles rectally as well. Helpful if somebody's having tailbone pain, bowel movement issues, sometimes other types of pain as well.
It's really interesting because I think there's definitely a large percentage of women who feel very nervous about going to see someone for pelvic issues, and they may even be aware that there potentially is a problem there. And I'm thinking especially more in signs of even prolapse. They know that something doesn't feel right, but it's that embarrassment or awkwardness of going to see someone who's going to be able to treat them. And it's really important, I think, that women can hear what you're saying and that it's a gentle approach. You're very much talking them through it. It's a very different experience to other more intimate, I guess, medical examinations that they may have. And I think this is really the importance of distinguishing that difference with pelvic physical therapy.
Yeah. I have to share with you, Lauren, this might make you giggle. So I went through 4 months of intensive pelvic PT for just terrible pelvic pain. And I kept telling my pelvic floor physical therapist when I went in that I was going in to do vagina yoga, because it was just such a different environment. And in my head, I had this before I started, that it was going to be this very cold experience. Like when you go to the OB-GYN, and right, that serves its place. But it ended up being a much more warm and at my pace type of therapy. And it was a very thorough examination. I mean, I learned stuff about my own body that I had never even thought about before. So as you're kind of talking through the exam, right, we don't get those types of exams, most of us. And for some reason, just thinking about it as vajoga put it in a different mindset for me. I was like, all right, go and do some vagina yoga today. Let's do this, the strengthening and the stretching. So
I remember that, because when we first started our company, and Kirsten and I were having these conversations, and she was saying, yeah, I'm doing, vajoga. I'm like, what's that? Is that a new thing in the US? We don't have it over here in the UK. What is that? So it was interesting.
No, I love it. And I think the more we talk about it, and there are entire little cul-de-sacs and neighborhoods within my community that I think I've seen almost every single person that lives in that area. Or we talk about it with our friends, with our moms, with our sisters. We're hearing what to expect. So it's not as scary. This idea someone's going to stick a finger where? It's a little unnerving, to say the least.
Yeah.
It's like, oh, that's what they do. That's what they can help me with. Then you're maybe still a little nervous or a little anxious that first appointment, just because it's something new, but you're instantly put at ease.
Yep. I 100% agree with you.
It is. The more we talk about it, the less, I guess, of the stigma there is attached to it. And on that, I mean, we're starting definitely to see a lot more noise over here about incontinence. I say over here in the UK about incontinence, and it's good to see those sort of topics becoming more mainstream. But incontinence isn't just, as we've learned, one type of issue. There are various different types of incontinence. It's a different experience for different people. Can you tell us a little bit about what the different types are? And should it just be a natural part of getting older?
Yeah, so there are a couple different types of incontinence. And incontinence is basically anytime any fluid, any solid, any gas is leaving your body and you don't want it to. So that can be pee, poop, passing gas. Basically, if you want to hold it in and you can't, and it just slips out or sneaks out, that's incontinence. So most often, I hear people that have stress incontinence.
Mm-hmm.
So that is leaking, usually urine, when they are coughing, laughing, sneezing, jumping, basically anything that creates a physical stress within the body. The other really big one is urge incontinence. So this is when that urge to go, it just comes out of nowhere. And sometimes there's something that sets it off. Like I pull up to my house and I instantly need to pee and then I'm peeing. And of course, sadly, you can have both of those going on at the same time.
And what are the triggers? Why does it happen? What are the causes to it? Is it because you're getting older and your pelvic floor muscles are weakening, or is there something completely unrelated as to why that might be happening?
So aging can be definitely a factor. And a big part of that in women in particular is their estrogen levels are decreasing. So we'll see in all of the muscles of the body, including the pelvic floor, that the muscles aren't as strong, they aren't as elastic. So that's why quite often people say, oh, well, it's the moment I turned 60 or the moment I turned 55, I started to have these issues. But depending on where you live and what types of treatments you're open to, hormone replacement therapy can be incredibly helpful. If the vaginal tissues are on the more dry side and the muscles themselves aren't as lubricated and moving quite as well, you think about when your nose is dry and it feels really itchy and you're blowing it constantly. If my vagina is dry, I might have some urgency. It might make me feel like I need to pee even when I don't need to. So that can be a really big piece of it for women who have entered menopause or women who have recently given birth and their estrogen levels are still lower. And then the other big thing can be we can accidentally train ourselves to need to go to the bathroom. So every single time I walk in my door at home or at my office, I go to the bathroom. Eventually, I'm going to associate walking in the door with going to the bathroom. Same thing with hearing water running. If, every time I turn on the shower, I pee right before I hop in the shower, maybe I need to flip that. Maybe I need to pee first and then get the shower going. So seeing, are there some common, trends in your day where it's like, oh, the moment I open the garage, I need to pee. Well, maybe we need to, change that habit and that routine for a little while and reframe how our brain and our bladder are communicating with one another.
So that's interesting because there's definitely that age-old sort of, if you're on your way out some way, like, I'm just going to go just in case, meaning that there's no bathroom nearby on your journey, or you don't know how long your journey is going to take, but not necessarily needing to go at that moment in time. And so we hear that commonly. I think our parents, obviously, my parents used to, like, quickly go before we leave, just in case. But in what you're saying is unless you need to go, that's really bad advice.
And I think a part of it is just good planning. Now, so last night I went to a play and I knew it was an hour and a half play. We had just finished dinner. We were about to go to the play. So I knew, okay, I'm not going to have access to a bathroom for 2.5 hours. I just had 2 glasses of water and a cocktail. I'm going to go to the bathroom before we leave the restaurant so I don't need to go during the play. But then I also didn't go right before the play started, at the play. I didn't go the moment I walked in the door at home. So I planned,
Yeah.
okay, I'm not going to have access to a bathroom for 2, maybe 3 hours.
Yeah.
Should go to the bathroom every 2 to 4 hours. So now would be a good time. But I also wasn't letting it interrupt me and going before I left the restaurant, the moment I got to the play, also during the intermission, also after, before I headed home. So there's that happy medium of, can I plan? I'm just running a 15-minute errand and I don't need to go, then I don't need to go.
Yeah.
So, and I think it's that education, like you're saying, like every 2 to 4 hours, typically you should be emptying your bowel, your bladder. Oh, not your bowel, sorry, your bladder.
I did not know that, by the way. I did not know that every 2 to 4 hours we should be going pee.
But then I'm thinking about, I know, okay, before bed is different because you have a longer extended sleep, so you might not want to have a drink before bed. But also, I think there are women who suffer from urge incontinence, so that I can think of, that perhaps avoid drinking water because they think if I drink water, I'm going to be in the bathroom every 5 minutes. Can you talk about that? I mean, is it just water? Should they be avoiding water, or should they be avoiding drinking altogether, or just are there certain drinks they shouldn't have, or what would cause that irritation, or not irritation, but that urge to go?
Yeah, so irritation is actually the perfect word. When I am working with people who aren't drinking much water at all because they feel like every time they take a sip, they need to pee, I tell them, I know you're going to think I'm crazy here for a minute, but I need you to drink more water. They look at me like I've lost my mind. And then
Like, what?
yeah, it's like, no, I'm peeing or I'm going to the bathroom all the time. I shouldn't drink more water. But oftentimes the opposite is true. So when someone doesn't drink enough water, or they're only drinking things that irritate their bladder, and that's a little different for everybody, the urine is so concentrated that it really irritates the inside of the bladder. And that's why when you go, it's just a little bit of urine, or you go and you sit down and it was just a couple drops, but you really, really felt like you needed to go because that urine was so concentrated and irritating. So what I tell people is, you're not going to go from drinking 4 ounces of water to 8 glasses, 10 glasses, half your body weight in ounces, whatever kind of our end goal is. You're not going to do that overnight. But can we start with, one water bottle in the morning and maybe one in the afternoon? And can we consciously just take a couple little sips here and there, little sips of water throughout the day, keep it in front of you, use a straw, how do we make this easy for you, or easier at least? So with a little extra effort, you can get that water in and your bladder isn't so irritated all the time.
And what about in the night? I mean, that's a common one, I think, for men and for women, right? Again, having to disrupted sleep, you have to get up in the night. Is there a cut-off time you should be drinking fluids, or sensibly, I probably think maybe an hour or so before bed, I'm not going to have water, fluids, tea, whatever it might be, not coffee. But does that help for those people who have to get up in the night and pee?
Mm-hmm. So what I usually recommend is in the hour or two before bed, start slowing down how much you're drinking. Now you can still take a couple sips of water. If your mouth feels dry, that's perfectly fine. You don't need to, cut it off completely, but really slow down how much you're drinking in those 2 hours before you go to bed. And then for that last trip to the bathroom before you fall asleep, make sure that you sit down on the toilet all the way. Give yourself a moment to take a couple deep breaths, really let your bladder empty all the way, and then you should be able to go to bed and hopefully sleep through the night.
So I have a last one on, and this is a curious one. I know a few people who will sit on the toilet with their phone and scroll through and sit for probably longer than they need to. Does that have any impact on their pelvic floor, the sitting for prolonged periods of time?
So I certainly wouldn't recommend it. Think about going to the bathroom like almost any other activity. I should be paying attention to what I'm doing when I'm doing it. When we are focused on our phone, then I'm not paying attention to, did I sit down all the way? Did my body relax? So you should have that urge to go. And it should be calm. You should be able to get to the bathroom, with control. But then I'm sitting down, going to the bathroom. And when I'm done, I'm done. And then I move on. And for, I think, women in particular, people with vulvas and vaginas, sitting there and this opening, especially if you have a prolapse or some pelvic heaviness, I don't think it's doing you any favors.
Yeah. And so if we suspect that you might feel issue, or you might have pain, or some of the things that we've described in today's conversation, when's the perfect time to go and see a pelvic PT? I mean, do you wait? I know you shouldn't really wait till the issue is, really becoming a disruption to your life, but also thinking about those who may be considering having a child. Do you wait till you've had your child and then go and have the checkup? I mean, I know I was told after having a baby for 6 weeks afterwards, postpartum, do your Kegels, and that was it. There was no other pelvic floor education other than that. So what would be a good time to see a pelvic floor physiotherapist?
So I think in an ideal world, we would all see a pelvic floor physical therapist or occupational therapist for at least a visit or two, because there's so much that we can learn about our bodies that we frankly just aren't taught. So that would be an ideal world. Go and learn. Am I contracting my pelvic floor muscles correctly? Yeah. Should I be doing Kegels? Yep. How do I relax my pelvic floor? What are some just general stretches, exercises, things that I can do to stay in really good pelvic floor health so that when I enter menopause, if I have a child, I'm not having issues. And then from there, if someone is struggling or they do hopefully want to be proactive and are in a place in life where they can be proactive, I think certainly when someone gets pregnant, when they're thinking about getting pregnant, working with a pelvic floor therapist so that they're able to really understand what's going on with their body specifically, because not everybody's the same.
Yeah. Yeah. I love what you said, Lauryn, about, in a perfect world, we all see a pelvic floor physical therapist or OT because, a lot of the individuals that Helen and I speak with will sometimes say, oh, well, I'm not in menopause, I don't need to worry about it. Or I never had a kid, I don't need to worry about it. And I think you speak very eloquently to the fact that it's not about worrying, it's about being proactive and really caring for a part of your body that is so central to core function. So I think you highlighted that really nicely. I do have one question for you, because it was something you said about, should I be doing Kegels? Can you talk about that a lot? Because this is one that I think is a common misconception, that this is the one thing that everybody should be doing no matter what. And maybe you shouldn't be. Can you talk a little bit about that?
So the pelvic floor, it has a couple of different roles. And the biggest one, honestly, is stabilizing. So when I think about, the pelvic floor, it's at the center of the body. It's working to provide a lot of stability and a lot of support. That's something that it does hopefully naturally all day long. So just like my abdominal muscles, the small muscles in my back, they are quickly churning on and off, working a little more and a little less all day long. I'm hopefully not walking around, squeezing my abs, relaxing my abs, tightening my back, relaxing my back. So why would I do that with my pelvic floor?
Yeah. Yeah.
There's certainly a time and a place for Kegels. I don't want them to sound like, oh, never ever do a Kegel ever again in your entire life. But knowing why you're doing it, am I contracting so I can feel that tightening so that then I can feel the relaxing? Maybe I sneeze when I pee, or I pee when I sneeze. So I need to remind those muscles, hey, you need to contract and stay contracted while I sneeze so that I don't leak. But then afterwards, you can relax. there's a time and a place for Kegels or contracting and relaxing the pelvic floor, but I don't need to do 300 Kegels every day to have a strong and stable pelvic floor.
Yeah, I thank you for diving into that. Because prior to my pelvic PT, I had a hypertonic pelvic floor. And they were kind of, lack of a better word, layman's terms here, but like my worst enemy. And here I was thinking, let me just keep doing Kegels before I went. And so I think even for me, rewinding pre-PT, that was my thought process. And I think it's kind of the one term we hear all over. And so we gravitate towards it, but without, to your point, understanding why we're doing them or the frequency or the volume of why we're doing them. So I think you might have dispelled some things right now for many of our listeners.
And I do think there are many women who want to be proactive, especially, you know, pelvic health is becoming a little bit more topical, thankfully, and think, okay, I need to be proactive. Where do I start? You know, and then it's that first jump into it. Think, okay, I need to do Kegels. And as you're saying, it could be the right thing for them. It could not be the right thing for them. So I don't know, what would your advice be to someone who wants to start being proactive about their pelvic health? Where should they start?
So honestly, where I start with a lot of my clients is with breathing and just connecting with the pelvic floor. So get a mirror, use your hand. Are you a visual learner? Are you a tactile learner? You know, how do you best learn things and connect with your body? And seeing, you know, can I come into a comfortable position? Maybe that's sitting, maybe that's lying on my back or lying on my side. And can I, you know, take my hand or take my mirror and see, can I breathe all the way down into my low belly, into the area between the sit bones? Think about breathing down into all of the openings and see, can I feel that lengthening? And it's a small movement. You know, I'm not doing jumping jacks or cartwheels, but can I feel that lengthening? And you might not. It might be really hard.
Yeah.
So that's where seeing, okay, well, what happens if I do tighten and I contract? Can I feel that letting go? Can I feel that dropping? So just starting to connect with, can I consciously control this area of my body and feel it move? I think that's a beautiful place for anybody to start with.
Fantastic. I do have one more question if I can ask it, because you mentioned a pelvic floor physical therapist or an OT. Can you just briefly explain the difference between those two for our listeners? Because I'm not sure that's common knowledge.
Mm-hmm. Yeah. So in an ideal world, pelvic floor PTs and OTs would practice very similarly. So we are both coming in as experts in movement and how the body moves, and experts in helping you live your life to the fullest, whatever that looks like. So PTs tend to come in with a little bit more of a movement approach, whereas OTs come in a little bit more with a psychosocial approach. But at the end of the day, we should be practicing pretty similarly, combining both of those approaches so that you are taken care of as a whole person.
Well, that's excellent advice. I definitely learned so much from you today, that's for sure. And I'm sure many of the people listening to this will be thinking, hey, giving some second thoughts now they've heard lots of things that you've discussed. Well, Lauryn, I just want to say on behalf of us, thank you so much for sharing your knowledge and sharing your expertise with us. And I'm sure we'll have lots of inquiries and questions about these things following up this podcast. But thank you very much.
Thanks for helping spread the word and get the word out.